invite the next speaker, the person from a rural area, a small town making it big, Shon Chinchole, to tell us more about Phaco in small pupil.
Very good morning, all. Dealing with small pupil in cataract surgery, the common causes for small pupil is advanced age, post-uveitic cataract, pseudo-explosion syndrome, diabetic patient, floppy iris syndrome, high hypermetropia, and prolonged myotic therapy, neurological conditions. Problem that I encountered during cataract surgery, that is, first is just doing the capsular axis, difficulty in visualization of rhexis margin leading to ill judgment of size, shape, and if any extension to periphery. Hydro procedures, inability to judge the correct dissection plane, leading to difficulty in rotation of nucleus. During the Phaco emulsification, smaller the pupil, poor the red reflex, which can lead to difficulty in judging the depth and strength that may lead to PCR. Risk of catching pupillary margin with Phaco tip, this happens usually. Involvent capsular catch and capsular trauma with chopper can cause posterior extension, and that leads to PCTR. Difficulty in cortical aspiration and implantation of IOL. This leads to iris bleeding, increased risk of iris damage, iris prolapse. Then again, if the iris catch is there, again the pupil will become small and the rhexis will be small, incomplete evacuation of cortical matter, problems in incurring in the bag IOL placement, difficulty with proper alignment of toric IOLs also. How to manage the small pupil? The posterior synechia can be managed with midratic, as Dr. Manish had told so many things about that. Subconjunctival induction of midracan. If patient is using myotic, ask to discontinue for 3 weeks before surgery. How to manage cataract in small pupil? Surgeon techniques and pupil expansion technique depends on pupil size and biomechanical properties of iris. What is the critical diameter for pupil to become a small? So these are the small pupil, even you can do it in 2 millimeter, 3 millimeter, 4 millimeter. The pupil size relieved to surgeon's skill and technical skills, intraoperative situations, iris tissue properties. Surgeon skill and techniques, see, even this is without using any pupil expansion device or hooks. Use good OVD. Here I suggest decrease the fluidic parameters, because sometimes if the parameter is more, again that will lead to iris will come through the main port or side port incision. Always use, as sir said, whenever you are using the Phaco tip inside, go for vertical chop technique, because sometimes if you are using vertical one, you can't damage, or you can help that nucleus to bring towards the Phaco tip, and that will definitely help. Here also sometimes you can see there is iris catch. So, but because of the dialer or chopper, I am helping the Phaco tip to bring it inside. Always manipulate the nucleus in the center, because when the tip is in the center, definitely it will not going to damage the iris tissue. Use bimanual IA. As I said, why bimanual IA? Because if you are using both the hands, definitely that will help to go behind the iris, behind the pupillary margin, and you can catch the pupil. You can hold the capsule, and you can take all type of cortical matter and bring it in the center and aspirate it. So I always use bimanual eye while using small pupil cataract surgeries. Management of small pupil with viscoelastic agent stretch, which will stretch the iris, lead to deepening of the AC, and that leads to pupil dilatation. So here, as I say, whenever you are having small pupil, just do with iris. You can iris repositor, you can break the posterior synechia, and with the help of Y hook, both sides perpendicular to each other, you can stretch the pupil. You can see in this video, first I did with iris repositor, we break the synechia, then we do with Y hooks, we stretch it perpendicular to each other, and that will help you to make a pupil stretch, and definitely will going to help you for the further procedure. Sometimes after doing this also, if you think that there will be cyanic, the post-operative or intraoperative, intraoperative, it's going to meiosis. So give a small cut at the pupillary margin, and that will help you in doing the procedures. Here is one thing which is really great, but for the beginning, it's difficult for me also, because when you are using iris hook, you should know the tissue property or what is the main thing for the cataract, like it is a uveitis case or something. Because when you are using the iris hook, definitely you need to have 4 to 5 paracentesis incision. When you are using paracentesis incision, make it sure that when you are putting the paracentesis incision, you should not damage towards the iris tissue. Otherwise, that leads to bleeding, and that may again, during the procedure, sometimes it may get shallow anterior chamber, and if shallow anterior chamber is there, that will definitely giving you some trouble while doing surgeries. One more thing is that even though you are putting 4 hooks, you may need one more hook, just because if one more hook is there, that you have to be at the, when you are going to put the phaco probe, from the same point, iris tissue will come inside. So the 5th iris hook should be behind the main port. These are some pupil expansion devices. I am using BHEX pupil expander. The procedure will be like the same, do synecholysis, breaking of the posterior synechia. Here, there are 2 things which are more important. You will get good hexagonal shape of pupil. How to insert it? There are 2 types. Either you go with the forceps, here as it is, or you go with the Sinskey hook. Both with the Sinskey hook or with the forceps, only thing is that make it sure where is the holes, because sometimes it's very difficult. We can insert it properly, but while doing, while we are going to do behind the iris, times it's difficult to go inside, and that again may lead to iris tissue. But it's very easy when you are going to have that hexagonal shape. The CCC will be proper, and it will give you a good surgical skill. Gupta pupil expander, this is also a good one, but need injector and cartridge. Only thing is that it is more helpful when you are going to have a square shape, and that will definitely help you to have a good surgical skill. Management of intraoperative meiosis, this is more important, because after doing everything, suddenly you can see, because of iris tissue or some handling with the tissue, with the, either with the dialer, chopper, you may get intraoperative meiosis. That nowadays a commercially available injection, tropicamide, phenylephrine, and lignocaine is there. You can put it inside, and again you can have a good look, and you can insert the lens. Advantage of hooks over the pupil expander. Technically much more easier to insert and remove. Pupil expander is difficult to insert after capsular axis. The iris hooks are much more reliable in such cases. Advantage of pupil expander over iris hook is no need for extra paracentesis, easy fixation points are there, smooth edges, less trauma to iris tissue, and flexibility. Thank you very much.
Thank you. Sir, yes, go ahead.
Yes, sir, go ahead.
Sir. Yes, sir. Yes, sir. Now it's not available, but before.
Nobody explained about the intracameral use of adrenaline, and I think we are forgetting the subconjunctival use of gentamicin and dexamethasone at the end of every cataract surgery. Still, I think dexamethasone has got good role
Right.
as far as inflammation is concerned, and adrenaline, intraoperative meiosis is prevented, bleeding is prevented. I am using adrenaline in each and every case in AC maintainer through that line. Number
Right.
3, as a rheumatoid, this thing, cycloplegic and all other things, they are not useful. After operation, subconjunctival or subtenon use of depomedrol, that gives good anti-inflammatory effect for 21 days or more than that. So this is my observation. If anybody knows about depometrol, it is welcome. Thank you, sir.
Thank you, sir, for your suggestions and tips. Thank you, Shon. You have very well explained about how to manage small pupil in cataract surgery. There are different options. Whatever option you feel better in your hand, I think we should opt for that. So, excellent presentation as usual. Shon, thank you so